Dr. Charles T. Daughter, the father of interventional radiology, introduced transluminal angioplasty more than 50 years ago, revolutionizing patient care and saving millions of lives across the globe. Each year, we acknowledge his contributions with the Daughter Lecture, which recognizes an individual who has delivered extraordinary contributions, shown exceptional achievements in the field, and contributed outstanding service to our society. It is our honor this year to announce our 2018 Daughter Lecturer, Dr. Timothy Murphy. Dr. Murphy is currently Medical Director of the Vascular Disease Research Center and Interventional Radiologist at Rhode Island Hospital. He is also Professor of Diagnostic Imaging at Brown Medical School. And now, please give a warm welcome to our 2018 Daughter Lecturer, Dr. Timothy Murphy.
Good morning, everyone. There's already been a mistake. That wasn't my song. Thank you, Suresh. It's truly humbling and the highest honor of my career to be asked to give the presentation to the Society. Suresh, thanks for the kind introduction. I appreciate you saying that you followed my career path, but you eclipsed me long ago, and I think that's fantastic. I couldn't be happier. I want to thank my family for making the trip here. My children, John, Madeline, and James, 13, 15, and 15, who came here unaccompanied, 3,000 miles to hear a lecture they won't understand anything about. Nice job, guys. My lovely fiancée, Ty Mullen, she was accompanied. And my father, Dan Murphy, who is a jet setter. He came in yesterday. He's flying home today. So I hope it's worth it, guys. I do want to share, it's fantastic to have my family here. I want to share one piece of advice I got from my 15-year-old son, James. He said, "Dad, don't throw up." These are my disclosures. They're not relevant to this presentation. This is the first known arteriogram. This arteriogram was obtained in 1896, which is 1 year after Röntgen discovered the X-ray. It was done with petroleum and calcium carbonate-based solution. Fortunately, this was a cadaver, because otherwise that probably wouldn't have worked out very well. But you can see it's a very good rendering of the arteries of the hand. Approximately 20-plus years later, the field had progressed. This is actually an image of a venogram from 1923, which was done by Berberich and Hirsch. I can kind of make out some of the blood vessels. They used strontium bromide as their contrast agent, and this really was probably the first study of blood vessels in humans. The first clinical radiographic visualization of leg arteries was published by Barney Brooks in the Journal of the American Medical Association in 1924, and you can see in these images that there's very good rendering of the arteries below the knee. This arteriogram was done with sodium iodide solution. Brooks started with sodium bromide, then moved on to sodium iodide because of its better radiographic properties. This study was done by a cut down of the superficial femoral artery adductors hiatus. Then the field moved on to cerebral angiography with the Portuguese neurosurgeon Agus Muniz, who, in one of the creepier experiments of all time, cut off the heads of cadavers, moved them to the radiology department, and injected them with various radiologic substances until he found some that he thought worked. This arteriogram was obtained in 1932 with a 25% sodium iodide solution, and this was done by either cut down or needle injection in the carotid arteries. For this work, Muniz received the Nobel Prize in Medicine in 1949. As the field progressed, the next advance was a colleague of Muniz named Reinaldo dos Santos, who was a Portuguese surgeon who performed arteriograms by translumbar access. You can see the needle here in a fairly decent arteriogram, which was obtained in 1929. However, the field was limited because of the toxicity associated with inorganic iodine injection. People who got injection of inorganic iodine more than approximately 10 grams often had what was termed at the time iodism, which is thyrotoxicity, either hypothyroidism or hyperthyroidism. The field progressed considerably after the discovery of the radiographic properties of the antimicrobial agent Selectan neutral, or Euroselectan, by Moses Swick in 1929. Although Werner Forssmann first catheterized the heart in 1929, right heart catheterization was not really developed until the 40s with the pioneering work of Cournand and Richards. Prior to that time, the original way that organs were imaged in the body was to inject contrast and obtain radiographs. This technique, known as angiocardiography, was pioneered by Robin Steinberg at Bellevue Hospital in New York, and they published their work in 1938. Castellano was also credited with one of the earliest angiocardiograms in Cuba, also around that same time. The imaging of the heart was done by manually injecting approximately 40 milliliters of diodrast, which was the main contrast that was used in the 40s, by a needle that was injected in the antecubital vein, and then obtaining radiographs over the chest. These are some of the first images of internal structures of the body, including the heart, the valves, the chambers, and the great vessels. This is going to be a talk about innovation, and in a sign of how new discoveries can be received with hostility, this was first presented at the American Roentgen-Ray Society meeting in 1939. Steinberg's wife was in attendance during the presentation. He heard one of the attendees say, "This is not true, they're lying." And this is just a demonstration from one of the manuscripts about how the procedure was done. They got a large bore needle directly accessed into an antecubital vein. The radiologist stood on top of the patient and injected the contrast. The contrast flowed through the venous system into the heart, and they had a film changer that obtained the radiographs. This is where Daughter comes in. After medical school, Daughter went into the Marines, and then he did his residency at New York Hospital. In 1948, he started as an instructor working with Dr. Steinberg. An instructor is probably analogous to a present-day fellow. And this is a picture of Daughter doing an angiocardiogram in the 50s. Over the next 25 years, particularly throughout the 50s, most of Daughter's publications in the 50s focused on angiocardiography. Over the next 25 years, they co-authored 46 articles out of Daughter's 215 that appear on PubMed. Daughter's first publication on angiocardiography was published in the New England Journal of Medicine in 1948. They also wrote this definitive textbook on angiocardiography in 1952. Angiography was also beginning to take shape about that time. The term was very new. Daughter wrote this article in 1951. In the article, he defined angiography as registration of the outline of a vessel on photographic media through the use of radiant energy. All of this was either done by direct needle injection or by venous injection. Here is a translumbar aortogram obtained with methods very similar to those used by Dos Santos that appeared in that same paper from 1951. The next major advance in our field was Seldinger's method of access, and everybody's familiar with it because we use it all the time. And it really resulted in the expansion and particularly enabling selective catheterization. In what he describes as an attack of common sense, Seldinger changed the order of catheter introduction. Initially, it was needle, catheter, guide wire. One day he was looking at the three components, and he said it should be needle, guide wire, catheter. And that was published in Acta Radiologica in 1953. However, it's hard for us to transfer back 60 years and understand the impact of that paper, but it doesn't appear to have immediately taken off as a technique, surprisingly. This is a paper that was published by Stan Cope in the New England Journal of Medicine in 1958, where he describes essentially an angiocath or an intracath. And it was a method of putting a needle in polyethylene tubing, heating and stretching the tubing, and then cutting the tubing off so that you had a catheter wrapped around a needle. Previously, the needle got access into the blood vessel, and then the catheter was threaded through it. And that resulted in some problems because the needle needed to stay in place during the procedure, and there was also a mismatch in the size of the access with the catheter. However, it's interesting to me that 5 years after Seldinger published his breakthrough method, they're still talking about ways to obtain angio access and to do imaging. Similarly, this was described almost about the same time by Daughter. This is a different method of introducing a catheter into blood vessels, also not Seldinger's technique, but a modification of the needle catheter access technique. And in this method, Daughter placed a side hole in the catheter, and then he stuck the needle through it so that the needle protruded a little bit from the end of the catheter. He then would obtain needle access into the blood vessel and advance the catheter, take the needle out, and put the guide wire through the catheter and go where he was going. Note that this was 5 years after Seldinger published his method. Just shifting gears a little bit, I mentioned briefly the work of Cornan and Richards and Forsman in doing right heart catheterization and putting catheters in the heart, where Forsman put the catheter in and measured pressures, and then Cornan and Richards expanded on the physiology and eventually led to right heart catheterization with contrast injection. This is a picture of Mel Judkins, a radiologist who was a fellow and colleague of Daughter's, and Mason Soanes, who did the first inadvertent right coronary artery arteriogram during a heart catheterization procedure in 1958. It was really during this time, and really in large part based around heart catheterization, that selective arteriographic methods were developed, and Seldinger's access was adopted once and for all. And then this happened, and many of you have seen this. This is an abdominal arteriogram done by Daughter in 1963, where he had a patient who had diminished pulses. He obtained access through the right common femoral percutaneously. He advanced the catheter and did the arteriogram, and he found out, lo and behold, he had placed the catheter through the occluded right iliac system. The artery was either occluded or it was occlusive to the catheter. Often, observations that lead to discoveries are made by serendipity or by accident. Ray Kroc, the founder of McDonald's, said that sometimes opportunity involves being in the right place at the right time, knowing that you're there, and taking action. And in this case, Daughter could have just done his arteriogram, obtained hemostasis, and moved on to the next patient, but he didn't. It had an impact on him, and he thought about it. Now, around this time, Joseph Resch, his longtime colleague at Oregon Health Sciences University, was organizing the first meeting of the Radiologic Society, Radiologic Congress of Czechoslovakia. Daughter and Resch had started a correspondence many years earlier because Daughter had come across Resch's articles on pancreatic venography and splenoportography. There were 84 speakers that were planned at this convention to be held in Czechoslovakia in 1963. One of the people invited was American, and that was Charles Daughter. Daughter contacted Resch and said, they offered him a 30-minute slot. He said, well, I'm coming 8,000 miles. Could I have 60 minutes to talk? And so they said, okay, you can have the 60 minutes. He then went and spoke for an hour and a half. He discussed balloon-directed catheterization, occlusion catheterization, catheter biopsy, catheter endarterectomy, stent grafting, etc. Although the talk went long, Dr. Resch was gratified and said it was the most exciting lecture he'd ever heard. This is a picture on the right of Daughter giving that presentation at Carlo Viveri in 1963. And all of you have heard this quote where Daughter concluded the lecture by saying, the angiographic catheter can be more than a tool for passive means for diagnostic observation. Used with imagination, it can become an important surgical instrument. Note that this was in 1963, and he had not yet done any angioplasties or any interventions. However, his opportunity came shortly thereafter, January 16th, 1963. This is Laura Shaw. I apologize if this is a HIPAA violation. This information is out there. She was the first patient ever treated with percutaneous catheter-based intervention. Laura was an 83-year-old woman at the time who had gangrene of her left foot, third, fourth, and fifth digits. After trying the technique of catheter-based angioplasty using serial dilators in cadavers, Daughter did the angioplasty on Miss Shaw. You can see after the dilation, there's some residual stenosis, but he's really treated that proximal popliteal lesion fairly significantly. After this, her gangrene, the toes sloughed, the wounds healed, and she survived for 3 more years and then died of congestive heart failure, never needed any other procedures on the foot. These are the notes from the chart on Ms. Shaw, and I don't know if you can read this, but the first note is from an intern that says, presented to Dr. Adams, who feels we have absolutely nothing to offer the patient. The second note says, patient refuses amputation. The third note is daughter's note in the chart, obstruction dilated percutaneously with resulting lumen about equal to the previous lumen. And on the right is his dictated or transcribed note of the procedure, which reads like a standard angioplasty note, although that procedure had never been done before. And everybody knows that this was the seminal paper that got the field going. It was published, 11 cases that were reported, published in Circulation in 1964. This is a daughter doing one of the early angioplasties, and you can see from the image on the left, there's a very long femoral artery occlusion, and after his daughtering technique, you can see the vessel is widely patent. That procedure was done in 1965. If I did that procedure tomorrow, I'd give myself a pat on the back for it. Let's hear from Dr. Daughter himself in this brief 1-minute video.
Here, the first look shows the stenosis. Now to thread the guide through it, always under fluoroscopy and with care. The patient watches.
It looks like we have it made.
Yeah, it looks good, but let's not count our chickens for another day or so.
He had a right to be pleased.
3 times around and still no pain. Looks like my ream job's working.
Amen. It is reasonable to hope that transluminal dilatation will someday replace the current management of renal artery stenosis. Perhaps it will have a role in a future sophisticated attack on coronary narrowing. So much for the future.
Now that was 1965, and he'd already predicted its use in other territories other than lower extremities, and this doesn't appear on this video, but he also talked about it potentially as being a therapy for stroke. Although not initially taken up in the U.S., the technique of daughtering using serial dilated catheters was embraced in Europe. Many of you are aware that Eberhard Ziegler published 570 procedures in 498 patients in 1973. And Ziegler introduced the methods of daughter to Andreas Grunzig. Grunzig became energized and started to try to envision a better way to do the dilation than serial catheters. He developed, with the help of Schrumpf, an improved angioplasty balloon that he started to use for peripheral angioplasty in 1974. In 1976, he performed the first renal angioplasty, as well as coronary angioplasty in dogs. He presented that poster on the right at the American Heart Association meeting in 1976. The next year, he did the first angioplasty in humans, and that resulted really in a rapid growth in the field of interventional cardiology. And to a large extent, we recognize Daughter as the father of interventional radiology, but he also deserves credit as the father of modern interventional cardiology and the father of modern vascular surgery. Moving back to just go over some of Daughter's other accomplishments. Daughter was a tinkerer with a capital T, according to his daughter Jane. At 32 years of age, he moved out to OHSU, became the youngest chairman of an academic radiology department, where he remained for 33 years. To improve the technique of angiocardiography, he wanted to improve temporal resolution, and that meant speeding up the ability to acquire images. At the time, X-ray tubes required exposures of about 1/10 of a second. In a beating heart, that results in a lot of deterioration of the image. So Daughter, along with an electrical engineer, developed a high-tension switch which improved the exposure times from 1/10 of a second to 1/1000th of a second. And you can see, looking at the image on the right, how much sharper the detail is compared to the image in the middle. I'll admit the image on the right isn't great, but the image on the left really looks like a myocardial perfusion scan. In addition to angioplasty, daughter published on almost every aspect of what now we consider to be interventional radiology, including the description of the safety, J-wire, low-dose catheter-directed fibrinolysis, arterial stenting, which he first described in 1969, CO2 angiography, etc. Now, this is an image from the Radiologic Society of North America meeting in 1963 that shows daughter speaking with Bill Cook. And everybody knows the story about daughter taking some of Cook's polyethylene tubing back to his hotel room and providing shaped catheters the next day that Cook then sterilized and sold. Daughter had a huge role in the development of the Cook Corporation, as he was a prolific inventor in the infancy of interventional radiology. Interestingly, I'm not a patent attorney, but I searched for patents that had daughter's name on them that were assigned to Cook or otherwise, and there's really only two of them that I can find, one which was a co-invention with Bill Cook, and another one which was a daughter alone, which he received for a coiled stent graft in 1985, actually after he passed away. So it appears that most of this relationship, and I don't know the details of it, was daughter giving the ideas to Cook and Cook giving him commercial-grade product that he could then use to help his patients. And daughter was a Renaissance man. Everybody has seen these. He was a mountaineer. I had heard that daughter climbed all of the peaks over 14,000 feet in the continental USA. In preparing this lecture, I learned that that was 67 mountains. That's a lot of time spent at altitude. The image on the bottom is actually daughter climbing the mountain with one of his patients who he had performed an angioplasty on. They were at 11,000 feet. This was daughter's trademark pipe and wrench, which he drew. Again, he was a multi-talented guy. This is daughter loved beagles. He would often take them hiking. This is a sketch that he did of one of the family pets that hangs in the living room of his daughter Jean's house today. This was done in 1959. Daughter was a very capable medical illustrator, and a lot of his publications had his own artwork. Here's a drawing of a pulmonary arterial tree that was done by daughter, tracheobronchial tree, etc. He was a multi-talented person. However, during an era when health risks of cigarettes were not as well known, and in fact there were cigarette ads that featured doctors endorsing various cigarettes, one's healthier than the other one, daughter was a smoker. Whether it was related to his smoking, his time exposure to radiation, or his time spent in the mountains, he was diagnosed with Hodgkin's disease at the age of 49 in 1969. He underwent aggressive mediastinal radiation therapy at that time, continued to work and published through the 70s and early 80s, even though they told him when he was diagnosed that he would be dead within 4 years. He subsequently came down with coronary artery disease and had 2 operations, the first in 1983, the second was in Milwaukee in 1985. Because of scarring and other technical reasons, the operation was not successful. He experienced pulmonary emboli after the procedure and respiratory insufficiency and was essentially bedridden the last 2 years of his life. He passed away in 1985, the same year as Soames, Judkins, and Grunzig. In the last 2 years of his life, while he was at home, he enjoyed watching football in a self-experimentation tradition worthy of Forsman. Occasionally, while watching the Raiders football games, he would run in an infusion of streptokinase on himself. Why not? Daughter's achievements did get widespread recognition, and he was to some extent a crossover celebrity, having been featured in an article in 1964 in Life magazine. The title of the article was Clearing an Artery. The article was fairly complimentary. However, daughter was distraught about it. He was distraught because of these pictures. He was told he would have final editorial approval of the article, but they didn't give him editorial approval of the pictures. The pictures gave him the appearance of a mad scientist and perhaps undermined the content in the article and the bright future that he thought his procedures had. However, it was typical of his treatment at the time. To quote Mel Judkins, Dr. Daughter has frequently been dubbed Crazy Charlie because of lack of understanding of his innovative and unconventional ideas. As vascular surgeon Frank Creato said in 2004, this name-calling reflected surgeons' near universal rejection of angioplasty as a viable treatment option. As you can see from this requisition here for his 3rd angioplasty patient, the technique was not rapidly accepted in all circles. However, I love this quote from Max Planck. An important scientific innovation rarely makes its way by gradually winning over and converting its opponents. What does happen is that the opponents gradually die out. And that, to a large extent, is what happened. In fact, going back to Forsman, who pioneered cardiac catheterization, and who, as a 25-year-old medical student in the 1920s, catheterized his own heart, was told by his superiors that such methods are good for a circus, but not for a respected hospital. And that his ideas were too crazy for him to be given a clinical position. He lost his clinical privileges. Forsman received the Nobel Prize for Physiology and Medicine in 1956, and Daughter himself was nominated with Grunzig in 1978. Probably too early. The winner that year was for the discovery of restriction enzymes, which are enzymes that cleave DNA in bacteria. Good going, Nobel Committee. Here are some of the other pictures that were in the Life magazine. You can see it's as if they went out of their way to pick pictures that made Daughter look like the mad scientist. As playwright George Bernard Shaw said, the reasonable man adapts himself to the world, the unreasonable man adapts the world to himself. Therefore, all progress depends on the unreasonable man. Daughter said, in the early days of transluminal angioplasty, I had to accept a lot of unpleasant backbiting, such as, he's a nut. I'm glad I was thick-skinned enough to stick with it. And that grit is an important part of discovery, which I'll talk about more. Now, we recognize Daughter as brilliant, but what is brilliance? We have standardized tests to measure IQ, and this is Louis Terman, who developed the Stanford Binet IQ test in the early 1900s. He gave the test to children, and then he followed them into adulthood. What he found was that people who scored well on the IQ tests had fairly average lives, and they didn't distinguish themselves with excess achievement. In particular, they didn't have a lot of creative achievement. As Terman said, we have seen that intellect and achievement are far from perfectly correlated. So where does creativity come from? This is J.P. Guilford, who was president of the American Psychological Association in the 1950s, and one of the earliest thinkers about creativity and innovation. And he came up with the concepts of divergent thought and convergent thought. Convergent thought being the standard thought that can be measured. There's a gathering of facts, and there's a single right or wrong answer. You process the facts, analyze the facts, and come up with the correct answer. Divergent thought, however, was solving abstract problems where there was no right or wrong answer. Convergent thought, again, being critical or analytic thinking. Divergent thought being creative, brainstorming type thinking. Now, when we talk about divergent thought can be extreme. One of the extreme examples of divergent thought is psychosis. The concept of the mad genius is not a new one. Aristotle has supposedly said, no great mind has ever existed without a touch of madness. And this brings to mind the story of John Nash of The Beautiful Mind. John Nash, as everybody knows, won the Nobel Prize in mathematics in 1994 for his concepts about rational thinking and game theory. Nash was schizophrenic, and he suffered from schizophrenia from young adulthood through the rest of his life. Unfortunately, John Nash is the exception to the rule. Most people with schizophrenia are not capable of extreme creative genius. In fact, Nash got the Nobel Prize for a paper that he wrote when he was 21 years old, and in the last 36 years of his life before receiving the Nobel Prize, he didn't publish a single paper. Psychosis is truly disabling. What about mood disorders? Are they the foundation of creative thought? Well, there's lots of examples in popular culture of people who were bipolar or suffered from depression who are recognized as creative geniuses. Can being bipolar or having another mood disorder help or explain creative discoveries? There's very little data on this. Nancy Andreessen, who's one of the leading psychologists thinking about creativity, did a study where she looked at 30 writers and tried to find match controls, non-writers, people who were not in creative jobs, and found that there was a significantly increased incidence of mood disorders, including bipolar disorder, in people who had creative careers. They were writers. 80% of writers actually had a mood disorder in this group, and 43% were bipolar, which was much greater than the other group. And there have been other authors in that field. Jameson in 1988 found that 38% of British writers and artists had been treated for mood disorders. In 1994, Ludwig also found higher rates of anxiety and depression in people with more creative jobs. However, there are problems with these data. First of all, there are very few papers. They're not very scientific. 10% of the population suffers from mood disorders. Creativity is hard to measure. I would look at these data and not draw really any conclusions from it. There's lots of people who are creative and considered to be brilliant or geniuses that do not suffer from mood disorders. However, here are some of the quotes that we're familiar with about Daughter. Daughter had 30 brilliant ideas a day. It took the rest of us to figure out which one was really worthwhile. And Charles' mind always operated at full throttle, often working in several directions simultaneously. Some of these quotes do sound manic. However, there are no reports, including from his family, of Daughter having been treated for any mental health disorder. In particular, he's described as upbeat and optimistic. The name Crazy Charlie doesn't really fit. Daughter was just someone who always had the pedal to the metal. Now, this is the Daughter Memorial Lecture, but there have been lots of people in interventional radiology that have made critical advances that have brought us to where we are today. IR has a great tradition of innovation, as we heard from Suresh touching on some of the things that are on the horizon even today. We continue to evolve and continue to have innovation as the core of our specialty, and that's why we've been successful. This is a real t-shirt. You can go online and buy this, and I think people have seen this before. Interventional Radiology, Inventing Procedures for Other Specialties since 1973. That's been a little bit of our Achilles heel, is that the procedures are not sticky enough. When they get too successful, other people want to do them. How come our procedures aren't as sticky? Well, Daughter said in 1980, if we do the job well, we'll keep it. If not, we'll lose the techniques that we've developed. I hate to use this forum to disagree, but there are lots of things that go into play here, and it's not just whether or not we do the job well. I show this case by example. I didn't do it. There's a patient had a left iliac stenosis, a stent was put in. This is the post-procedure arteriogram. You can see in the left femoral region there's just lots of contrast extravasation. This is the CT scan, and I don't have a pointer, but the radiologist will be able to pick out. That stent was dragged through the iliac system from an ipsilateral access, out the arteriotomy, and into the subcutaneous tissues. That case was done by a surgeon, totally nailed it. So the point of that is that there's a lot more than quality that goes into this. We are in a fee-for-service environment. The traditional clinical services of medicine and surgery often control what happens at the hospital level. Radiology in the past has been regarded as a cost center. Hospitals have felt that radiologists have the radiology franchise, and that's what they should be happy with. And let's not make any waves by giving the surgeons a hard time or the internists a hard time if they want to do procedures that they're really not qualified to do. I'm going to show these slides. Many have seen them from Eamon Hobbes. I call it Hobbes' vicious cycle. And he talks about the threat to radiology that the migration of our procedures poses. In this case, the Hobbes' vicious cycle, the funnel of new innovations in the procedure is smaller than the procedures moving out. And he has the life cycle from the beginning, the development, the lifespan, and then moving on. And this results over time in shrinking of interventional radiology. There are a lot of threats to innovation. There are a lot of reasons why we have trouble with the innovations in. As noted in the 1997 Daughter lecture by Ernie Ring, the administrative and regulatory barriers to innovation are considerable. This is the NIH funding curve in absolute dollars, which shows that the funding has decreased 25% in roughly the last 12 years. As those of you who submit NIH grants know, it's very difficult to get grants, and it's become a numbers game. If you submit one grant and you don't get funded and you give up, That's hopeless. It's never going to work. You have to, a couple of times a year, be cycling grants in and hoping that you get one of them. This is the opposite of it, which is Hobbes' virtuous cycle, which is we have more innovations coming in than are migrating out. In this case, the field continues to grow and thrive, and we continue to have quality interventional, minimally invasive percutaneous procedures available to our patients. How do we achieve this? There's no magic switch that you can throw to foster innovation. Most innovation is grassroots. By that I mean that it started at your home hospitals. There are skilled and creative practitioners who have new ideas. Where do the ideas come from? Sometimes they come just as a shock of blue when you're in the middle of a procedure, or driving home, or having your breakfast. Daughter used to advise his colleagues, always think of interventional solution to your problems. I'll give a couple of examples. This is Joseph Resch with a picture of a percutaneous portosystemic shunt that was created in a dog in 1968. Resch stumbled upon this idea because he was doing a transjugular cholangiogram and he kept getting into the portal vein. He could have just blown by that, but he didn't. He stopped and he said, what can I do with this? Let's think of an interventional solution. There's another famous example, which is Julio Palmas struggled for years to come up with the ideal stent. And then he was in his garage and he was looking at a steel mesh that a mason had left there for some tile project he was doing in his house. And he said, this looks like what I'm trying to do. But I would recommend, if people want to get on the cutting edge of innovation, to keep in mind the bottlenecks. When you're in the middle of a procedure and you're finding that the procedure isn't going well, or there's a technically challenging part of a procedure, maybe accessing the portal vein during a TIPS, or getting the guide wire through an encrusted nephrostomy tube, whatever the case may be, when you get into a bottleneck, try to think, is there another solution here? I have this picture up. This is Billy Cohn. Some of you may know Billy is a heart surgeon from Texas. He works at Texas Heart Institute. A very distinguished heart surgeon. He's also a tinkerer like Daughter, and this is Billy in his garage. Billy is a tinkerer with a capital T like Daughter, and he's been a leading innovator in the cardiovascular space for about 20 years, making important contributions to beating heart, coronary bypass surgery, percutaneous left atrial appendage exclusion, the maglev bivacor artificial heart, among other things. Some of you may know the company TVA, which they call TIVA, which is a company that is dedicated to developing percutaneous arterial venous fistula. That's one of Billy's companies and an invention of Billy's. Well, I want to tell you a story that Billy told me that I think illustrates how innovation and invention can be done. This is a graphic of a mitral valve replacement operation. In a mitral valve replacement operation, the chest is open, the heart is open, the mitral valve annulus, the diseased valve, is removed, and then sutures are placed in a continuous fashion around I shouldn't say continuous, they're interrupted, around the mitral valve annulus. The way that they're done is you can see on the right, it's a suture with 2 needles on it and a pledget in the middle. And the way that it's done is the ring of the mitral valve annulus is sutured with interrupted double sutures. There's a critical component to the procedure, which is after you place one set of sutures, that next suture has to go in close enough to the last suture, the second suture from the prior set of sutures, that it doesn't damage the prior suture, but it's not too far away that the valve ends up leaking. And the way Billy describes it is that is a real bottleneck on open mitral valve surgery. He would say, you have to get in position, you have to spread your legs, get a little lower, get your loops on, look down in there, grit your teeth, sweat a little bit, and make that suture. And he realized, again, getting back to Seldinger's attack of common sense, that he should just daisy chain all the sutures together. And that eliminated 12 of the 24 sutures that are usually required for mitral valve replacement surgery. More importantly, those were the 12 most difficult sutures to throw. And he just now runs the whole thing in as a one continuous thing, 12 sutures, run them through the valve, bring the valve down, tie them off, and you're done. Cut the time to do the procedure in half. And this is obviously the right way to do this. People had done that surgery that way, the old way, for years, and nobody had ever stopped to think, how could we make this a little easier? As Einstein said, everything should be as simple as it can be, but not simpler. This is an example of that. When you're confronted with a bottleneck or a technically challenging part of a procedure, try to think, is there a better way? This is just a very incremental example from my own practice, a patient that we treated 20 years ago who had iliac artery occlusion. At the time, stents had been approved for a few years. We were just learning how to use them. We tried to get through blockages, and we got through this one. This 105 millimeter spot film was done, and it showed what looked to us like a cast of the true lumen in the middle of the blood vessel. And we didn't know what we should do because we were subintimal. And we thought, well, is that okay to do? Is that okay to stent, or are we going to create a catastrophe? And we stented that, and it worked out fine. Then we started to do more advanced interventions. This is a patient with bilateral iliac occlusive disease. We were able to get through on both sides. We were able to get through on the right side. On the left side, we got stuck, and we weren't able to get back into the true lumen. So in this case, you can run the video. We put a stainless steel stiffening cannula up the other side and said, let's just puncture our way in. And you can see moving the balloon from the occlusion with the stiffening cannula. We then ran the needle tip guide wire up. Can we run the video? And we puncture back into the true lumen. And in this way, we're able to revascularize this patient. And this is really the precursor to a lot of true lumen reentry devices. We did think about it clinically. We didn't think about it commercially, unfortunately. But this is the type of advance if you want to push the envelope that you can do in your own practice. And if you keep thinking that way, you can push the envelope way out. This is a case that we did 20 years ago of a 65-year-old man with claudication who we were able to open up with stenting using some of those advanced techniques. Now, you're going to run into some resistance if you want to innovate. These are a couple of excerpts from a grant review I had once. I wanted to do an animal procedure. I submitted a grant to the National Institutes of Health, and the review I got back was, the proposal is certainly innovative. However, it is unlikely to be applicable in patients without serious complications. That's kind of harsh because it's an innovative thing. Nobody's ever done the procedure, and you have no way of knowing that unless you do the procedure. The overall evaluation was even worse. It said the proposal raises significant ethical concerns and is unfeasible. Therefore, it is not recommended for further consideration. So you're going to have to take some humble pie from time to time if you're going to try to do some of this stuff. However, we know that discovery isn't always easy. This is Edison. When trying to invent the light bulb, he famously said, I haven't failed, I just found 10,000 ways that wouldn't work. There's a lot of heavy lifting that goes into discovery. It wasn't even his hardest project. He took 50,000 attempts to develop the alkaline battery and finally concluded by saying, genius is 99% perspiration and 1% inspiration. It's a lot of work. When Edison died, he left a notebook with 3,500 ideas in it. He had a rule for his employees where he wanted them to have 10 ideas a week. And that's something that we could consider doing in our own small way. Now, I'm just going to, as I wrap up the talk here, I'm going to talk a little bit about what we can do centrally. Again, I think innovation is a grassroots activity, but there are some things that the society can do to foster innovation. We have the foundation. The people on the foundation do a fantastic job. However, in 2017, only 630 members, which is about 18% of active members, contributed to the foundation. I think we could do a better job of that. The amount that was donated averaged across all active members to be only $117. Maybe there's a way for the foundation to change their grant programs to make them more appealing for donations. One of them might be having the ability for donors to donate to dedicated grant programs and or diseases. So maybe we could let, and I'm not going to tell the foundation how to do their job, but maybe we could let people vote with their feet. If there's a disease you're interested in, maybe you can dedicate money specifically to that. It creates some administrative problems, but I think it might help raise money. And more importantly, there are foundations like the Society of Vascular Surgery Foundation that raises up to 1/3 of their donations from the general public. So if you start taking donations for specific disease states, maybe you can improve the bottom line. I want to talk about some things that are happening at this meeting. If you're interested in innovation, Govind Srimath, who is a biomedical engineer from Memorial Sloan Kettering, has organized a couple of workshops over the last few meetings, and he has 2 startup workshops at this meeting. The first is medical device innovation, which is Tuesday, 8 to 10 a.m. The second is IR Moonshot Challenges about technology development that can fundamentally change clinical practice in IR, which is tomorrow, 8 to 10 a.m. I also want to mention the IR Venture Forum. It was mentioned in the introduction. Some of you probably know about it. The Venture Forum is not running this year, but it was part scientific session, part Shark Tank. It was a fascinating meeting. We had each year about 10 or 12 businesses would come and present their new technologies in IR and try to generate interest among the audience for investment. About 20% of businesses were able to raise money from people in the audience. This, unfortunately, had a little bit of a problem with the business model in that only about 40 members on average attended that meeting. And it was good, but it could have been better. So if this comes up again in the future, I just want to introduce it. It's a little bit of a plug, but I think it's an important activity that the society can do to help foster innovation. I know there's lots of people. Kieran Murphy has had ideas, and there are some other people trying to get some things going that might be more effective. But we should try to support new ideas when they come along. Well, it took a while. As I finish, I want to say that Daughter's ideas were validated, and a lot of the ones that he put a lot of work in eventually have come to pass. Eventually, the surgical community came around, coincidentally, about the same time that Medicare reimbursement of open surgery was cut drastically. I'm sure that was a coincidence. Today, most of the procedures that are done in surgery, some say 70 to 80%, are actually what they call endo, which is obviously a euphemism for interventional radiology. Again, as Dr. Criado said, remember, he's a vascular surgeon, the surgical community as a whole completely failed to understand the potential of angioplasty. It represented, without a doubt, one of the most refined expressions of collective stupidity and nearsightedness ever exhibited by a professional group. That feels good. I think Daughter would like that. Now, Suresh went through some of the things that are coming down the pike, and I think they're fantastic. There's a lot of exciting things. I've just listed some of the things that have come to pass since Daughter's time to just confirm how far we've come. There's been a lot of life-changing services, embolization, endografts, thrombectomy, abscess drainage, etc., that are part of our routine practice. So Daughter's vision of the catheter as a surgical tool and the ability to do less invasive percutaneous procedures has come to pass. Daughter wasn't crazy. He was right. There's been an amazing culture of innovation in this society despite all the obstacles that have been encountered. So in closing, I want to note, we've come so far thanks to many who had such great ideas. I think our future will be as bright because we're still crazy after all these years. Thank you.